So tonight we're going to talk about a few different issues regarding death and medical ethics broadly. Okay, we're going to talk about the definition of death, we're going to talk about physician assisted death, and we're also going to talk about death culture. Now, I just want to say straight up, this is going to be maybe a tough thing for some people to listen to. Death is one of those topics that evokes a lot of feelings and it can be maybe morbid or strange to consider. So I just want to let you know that. I will be talking about suicide. And toward the end of the presentation, especially whenever we're talking about Caitlin Doughty's work, I will be showing pictures that include human remains, corpses, that kind of stuff. So just beware. But it shouldn't be anything that wasn't in the class materials, and I just want to be upfront about that. So let's get into the topic, because this is a really complicated topic with a lot of different things, but it's one of the issues that just like constantly comes up in medical ethics, because it has so many layers. All right. So the first issue that we're going to talk about is basically the definition of death. But in order to do that, I also need to give like a little bit of a neuroanatomy lesson. Okay. And this is still taken from a Khan Academy lecture. Khan Academy is really wonderful. I would highly recommend checking them out if you ever need some extra brushing up on science or math or whatever else. They have more stuff than that, but that's what they're most famous for. And this is a human brain. Okay. And broadly, if without getting into too much of the detail, you can kind of divide it into three different layers. Okay. The oldest parts of the brain, I guess the most primal parts of the brain, are what are happening here in the hindbrain and a little bit in the midbrain. Okay, so your brain stem, which is exactly what this is, talking about, are the parts of your brain that control things like blinking, breathing, that kind of stuff. And then your midbrain and similar associated parts are things that control maybe emotions, that kind of stuff. But these are very old, and they're, neurobiological structures that we share with many animals that are vertebrates, right? The part of the brain that's highlighted here in like this greenish yellow, the forebrain, that's arguably the most advanced part of the brain. It's the part of the brain that has evolved the latest. And in humans, it's the part of the brain that's the most pronounced. So whenever you look at a brain and you see all of the wrinkly bit, that's what's going on in the forebrain. The cortex is really important, in particular for humans, the neocortex. So the stuff that tends to develop later in our lives toward the front. Okay. The reason that we need to bring that up is because a couple of the definitions of death are going to rely on a distinction between higher order brain, so that's referring to the forebrain, right? The wrinkly bits that control how we project into the future, our thoughts, whenever we're regulating our emotions. It's the really, really important stuff that really we don't think other animals can do to the extent that we can do. All of that's in the forebrain, okay? It's in the cortex. The involuntary stuff, and so we're going to talk about stuff like breathing or signs of just being alive, quote unquote. That's happening in the brain stem. Okay, it's happening in the mix of the midbrain and the hindbrain. Okay, here's why it matters. Okay, there are certain states that are not dead, but maybe we should call them near-death definitions. All right. The first one is whenever someone's in a coma. And what makes something a coma is that the person who's in the coma basically is not awake and they don't really show any awareness of what's going on. It's basically like they're asleep and they're unresponsive to things. Okay? This is in contrast to what some people might call a minimally conscious state. Okay? And in the minimally conscious state, the patient might show some response to the environment or the situation. They might, for example, open their eyes and make eye contact with you. They might be able to follow a light whenever a physician is shining in their eyes. You might be able to ask them a question and they'll be able to grunt or give some sort of reply. Although it's not, a really detailed reply, it seems as though they are replying. They might be able to react for commands that say, blink, right, if you can hear this, or wiggle your finger. And they don't, do it right necessarily, but it does seem as though they have some sort of reaction. Okay? This also contrasts with a vegetative state. And a vegetative state is something like where a person is aware, okay? One second, my dog is making a funny sound. I had to tell her to relax. She was really digging into her blanket. But the vegetative state is where someone is awake, okay? But they aren't necessarily aware, all right? So people who are in vegetative states, they might actually open their eyes. They might blink. They might, be asleep and wake up with open eyes. They might even respond to loud noises. So like if someone made a really loud clap, or like if they dropped something, you might catch a twitch. Or like if someone grasped their hand in a really strong way, they might pull it away. Okay. And sorry, my dog. So the people in the vegetative state might show some sort of reaction. But remember the anatomy lesson, right? That doesn't mean that their cortex or the wrinkly parts of the brain are functioning well. It might just mean that their brain stem is functioning. This matters for the next slide, okay? And then a term that you've probably run into as well is a persistent vegetative state, PVS. But basically all that is it's a vegetative state, so where you're awake but you're not aware. And it's a vegetative state that's lasted 4 weeks or more, okay? And so all of this is really important for assessing patients, especially patients with brain trauma. And you can make lots of assessments. So this is relevant to our definition of death because whenever we're trying to figure out whether someone is alive or whether someone is dead, we have to kind of consider some extant definitions. It used to be the case that we could just consider whether someone was dead whenever they started decaying, right? That's an obvious definition. Their body, has rigor mortis. It starts to bloat. It smells weird, right? Obviously dead in that case. We can't use that definition really because now we have organ donation, and this had the technology started getting much, much better in the 1950s. So a person who dies literally can save a dozen lives, and they can improve dozens more by donating their tissues. Being an organ donor is a really great thing to do because once you're dead, right, you obviously aren't using your organs anymore, and you can literally save people's lives by donating your organs to other people, okay? But the thing is, in order for the donations to happen, the tissue has to be basically freshly dead, not decaying, right? And so we face more pressure to be precise in our definition of death and not use decay. We don't want, the really intense parts of decay to kick in because a lot of people could benefit from our organs, right? I'm an organ donor, and that's kind of one of the pressures. So a lot of the definitions of death moved on from that to some other things. So one of the things that they talk about is the irreversible cessation. So basically, whenever something stops working, but stops working not temporarily, but permanently, it's not going to get better, right? Because certainly we could have a heart attack or we could have a stroke or something like that where it affects our hearts or it affects parts of our brain, but that can get better in some cases, right? Irreversible cessation means that it's stopped cessation and it doesn't seem as though the function is coming back. Irreversibility, right? And so the most widely used definition of death in medicine today is the cardiopulmonary definition or the cardiac death definition. But basically it means that your heart and your lungs no longer are working. All right. And one of the ways that they used to test this was the mirror test. Put it in front of your nose or your mouth, and if it fogs up, they can tell that you're breathing, even if they really can't see that your chest is working. Obviously, we have much more advanced ways of testing that. Something like an ECG or an EKG, where you can monitor the heart or whatever. But that used to be one way of doing it. Now, there's a complication here. And again, it's brought on by technology. In the 1950s, although the technology had been around for decades, the use of ventilators became more and more frequent, meaning that we could put patients on machines that would help them to breathe and that would help their heart to pump. Okay? So they could technically breathe and have a working circulatory system, even though their heart might not be working or their lungs might not be working. This machine is doing the breathing for them. So that led to people trying to posit a different definition of death, right? Because if the machine can keep someone alive, even though they aren't really alive, that's a potential problem. And so some people started to shift toward the whole brain definition of death, okay? So rather than someone having a functioning cardiopulmonary system, their heart and their lungs are working, they wanted to know, well, what happens if their heart and their lungs seem to be working, but their brain is dead? Is that good enough to call someone dead? The whole brain definition says yes, okay? And for the whole brain definition, the entire brain has to have irreversibly stopped working. So that means that basically, it's not someone who can breathe on their own. It's not someone who might be blinking or responding to certain stimuli. That indicates that the brainstem is still working. One of the ways, it's a crude way that you can test this, is by scraping someone's foot. Okay? Whenever we react to pain, we'll wince or we'll withdraw, right? That's not because our cortex is telling us to do things. That's, again, the primal older parts of our brain, right? If our entire brain were dead, we probably wouldn't have that sort of reply, right? Or that sort of response, okay? So some philosophers, though, they're like, look, I agree that just because our heart and our lungs aren't working, that they're working, that doesn't mean we're alive. And so we should probably look at the brain. But look, if the parts of my brain that, control my personality, that control my ability to use language, that control my ability to have deep, meaningful relationships with other people, that control really complex emotions, if those parts of my brains are damaged, I don't care if I can blink or if I can breathe on my own or whatever else. That is not being alive, okay? What I mean by death, these philosophers are going to say, is higher order brain death. And so they're going to say whenever the cortex, that wrinkly part, the outer part, the advanced part, whenever that part is irreversibly broken, that's whenever I die. I don't care if I'm alive, quote unquote alive, because I'm laying there and I'm breathing and I'm blinking and they can put a tube into my stomach to give me nutrition so my corpse can be sustained. I don't think that's life, these philosophers are saying. Rather, what they're saying is what matters is whether, those parts of the brain that control the meaningful stuff, are those damaged, right? Are those damaged? This matters, and one of the ways that you can test this, by the way, that's what this graphic is an EEG, an electroencephalogram. And you can basically put electrodes on the outside of the head to measure electrical activity. You could use something like an MRI, magnetic resonance imaging, that can tell where your brain is metabolizing energy. So you can do lots of stuff to try to figure this kind of stuff out. But the higher order brain death, right, is basically saying if the advanced parts of our brain don't work, we're dead, right? We're dead. Notice as well that it becomes more and more precise, right? More and more narrow with each of the definitions. We started with decay, surefire, but organ donation made us move on. We started with cardiopulmonary definitions. Those still exist in a lot of states, but then we realized ventilators could be doing a lot of the living for us. So then we moved on to brain assessments of death, and people there are trying to debate as to whether it's the entire brain, the whole brain definition of death, meaning you don't even have basic responses, right? Maybe you're not even breathing or blinking or anything on your own, versus the higher order brain death, where, look, it's a strange sort of phenomenon to describe, because I could be laying there, right? I could be breathing on my own. I could be blinking. I could be flinching at certain things, right? But according to a higher order brain death or definition, I would be dead if the forebrain parts were irreversibly damaged and they weren't going to get better, right? That's relevant for a lot of cases. Let's focus on one particular case. And this is the case of Jahi McMath. And I had you read the article about what it means to die from The Atlantic. This was a very famous case. It happened relatively recently. And basically what happened was on December 9th, Jahi, she basically got a tonsillectomy. Okay? And she was apprehensive about it, but she went in and she was brave and everything like that. And so she went into Children's Hospital in Oakland and she got the tonsillectomy. She actually recovered a little bit. Like she woke up from anesthesia. Things seemed to be going okay. She complained of some pain in her throat. She seemed to be bleeding. That's pretty normal for surgery, right? Someone just literally cut into your body. So they, they took her complaints and they gave her a popsicle, which, can help. They taste good, right? It could be something to alleviate stress, but also the coolness can help to alleviate a little bit of the pain. So that's what they did. Thing was, she eventually suffered massive blood loss. There was something wrong with basically the incisions. And because she suffered so much blood loss, she eventually went into cardiac arrest. Okay? And eventually, on December 12th, so only a few days after the surgery, she basically was declared brain dead by the hospital. Okay? So that day, December 9th, she had the surgery. She recovered a little bit. She lost a lot of blood, and she had cardiac arrest that same day, basically. A few days, they sort of declared her brain dead. All right? The thing was, or one of the core issues here is kind of like whether Jahi was actually dead and at what point, okay? Because she was on life-sustaining treatment, right? Ventilators, things that were giving her nutrition, and that allowed her body to basically stay alive. It allowed it to twitch every now and again. The family interpreted signs in one way, the hospital interpreted them in another way, but basically the hospital became increasingly comfortable with declaring her brain dead. But to the family, it appeared that she wasn't dead because she was there. She was breathing. She was still warm, right? And in cases of young women, they might even still menstruate. So there are functions of their body that are working, right? But the hospital felt that it was the life support measures that were doing that, not Jahi herself, so they declared her brain dead. Part of what's going on here is some ambiguity in law, and it's not the same in all states, but they largely build on this Uniform Declaration of Death Act, which happened in the 1980s. It was a response to the ventilators, right? And here's what it is, okay? Here's what it is. An individual who has sustained either, 1, irreversible cessation of circulatory and respiratory functions, so that's the cardiopulmonary definition, or 2, irreversible cessation of all functions of the entire brain, including the brainstem, is dead. A determination of death must be made in accordance with accepted medical standards. Okay? The or there is really important. Okay? It's really important because this means in states where this is the standard, the physicians, the medical professionals, they can decide whether they're going to abide by the cardiopulmonary definition or the whole brain definition, depending on what evidence that they have. Right? In California, it was perfectly within the legal right of the physicians to declare Jahi dead. All right? The family disagreed. They brought a legal battle. They asked for Jahi to be transferred. No one else in California would basically take her. So that's usually what happens. Patients are free to request transfers, but then the hospital will kind of call around to other hospitals to see if anyone will take the patient. No one would, right? And they kept fighting things. They got a lawyer. The lawyer fought basically the brain death and some of the diagnosis to buy some time. And eventually what happened was the family basically concluded that Jahi might have been disabled, but she was not deaf. And they requested that she had the life-sustaining treatments, just continued giving it to her, right? But the medical team was like, look, I'm sorry. It's really horrible that you lost your daughter, right? She was a young woman with a lot of potential, really lovely, but she's dead. That's that's a corpse. That's not her. The only thing that's keeping her alive is the machines. And because she's not going to get any better, any care that we give her, the ventilator or whatever else, is going to be futile. It's going to be useless. It's not going to do anything to improve her condition. She's dead, right? Well, the family fought this, and they eventually transferred her care to a care facility in New Jersey, because there in New Jersey, the law was such that it could be interpreted that she wasn't dead in New Jersey. So in California, they had declared her dead, but they wouldn't have declared her dead in New Jersey because of the wording of the laws. All right. Well, this went on for basically 5 years, and then eventually she died, full stop, and a death certificate was issued June 22nd, 2018. All right. There's a lot of really complicated things about this case. All right. One is a matter of education on death and neurobiology, right? Medical teams have to do a good job of explaining how someone can be breathing, or how someone can flinch but still potentially be brain dead, right? Or be dead in certain ways. Because look, it doesn't appear that way. It's a very strange phenomenon to see someone moving and breathing and metabolizing energy and stuff like that, and saying that nonetheless they're dead. So medical teams have to be very careful about explaining stuff like this, right? And a lot of this comes down to effective communication and tact, especially in the case of Jahi McMath. There was a lot of scrutiny about how the medical professionals, especially the physicians, communicated the diagnosis and what had happened to Jahi. All right? Doctors, for various reasons, maybe they're stressed because they're attending a lot of people. I mean, especially in pediatric rotations, it's really stressful because you're dealing with young children. Maybe there's an arrogance, maybe they're extra tired, who knows? But if you say things in a non-tactful manner, that can really upset people, and it can make it such that your message is not heard, right? That was definitely part of what's going on here. And in addition to this, medical professionals need to be sensitive to justice. Jahi and her family are black. They were in Oakland, okay? The medical industry can sometimes be seen as arrogant or detached from everyday lived experience. It could have been seen by, I mean, not just the McMath case, but other cases, it could be seen as like a socioeconomic thing. They just want to rush me out because I don't have money to pay for the best treatments, right? And additionally, we've read other stuff about how pain reports by women and minorities are not taken as seriously. They just aren't given the same sorts of medical interventions as especially white people and white men, right? Whenever a white man complains, they are given much more medication or many more treatments by doctors than women or than by people of color. All right? They could have been sensing some stuff that was going on. That makes this case even more complicated. Now, it might not change the facts, okay? It might not change the facts that she was indeed dead after the cardiac arrest, okay? But, given the history of medicine and race and class, right? And given just the stress of this is where teams really need to be careful. And we haven't talked too much about, just clinical ethics, but especially in working in a hospital, often you can call for an ethics committee meeting, or you can call chaplain services, or you can call for social work, or you can call for hospice and palliative care. All of these people that can help to explain what's going on and communicate effectively with the family. Communication is key here. Communication is key, and that didn't seem to happen very well in this case. So let's apply this to the definition of death, right? The higher order brain definition definitely would have declared Jahi McMath dead, right? She had lost function of the higher order parts of her brain. Even if she was twitching or whatever else, that didn't mean that she was talking, she had complex emotions, whatever, right? She was dead on that definition. The whole brain definition, that's a little more controversial and a little more complicated, and I obviously don't have access to the medical charts or anything like that, but this is kind of what the family was fighting over. They were saying, look, if the standard is the entire brain being dead, how is it the case that she's still twitching and doing stuff like that? The doctors basically explained that that wasn't actually a response. That was just like random things that organisms do, right? The cardiopulmonary definition, she definitely wasn't dead because her cardiopulmonary system was still working. That's why she was able to get continued care in New Jersey. Decay, obviously she wasn't decaying. So this is a case where legitimately the definition of death was affecting a lot of different, outcomes in this particular case. And because there are differences between states, it led to the really confusing thing of Jahi McMath at once being declared dead in California, but not being declared dead in New Jersey. So these things have real import, right? Okay. That's the first thing. Definition of death, complicated debate. Second thing that I want to talk about is aid in dying. And this is basically, I need to make some distinctions about these kinds of things. Generally, this happens in discussions of what's called euthanasia. Euthanasia coming from the Greek word eu, meaning good, thanatos, meaning death. So basically, it means a good death. Generally speaking, however, these are cases where you're killing someone or bringing up about the death of someone for their own sake. You're trying to give them a good death. All right? That's what euthanasia generally is taken as. But there's a lot of different ethical distinctions we can make here. The first one is between active and passive euthanasia. Active is basically doing the killing. So if you are engaging in a mercy killing or euthanasia, and it's an active case of euthanasia, it's a case where you are, for example, pushing the medication that will put them to sleep and eventually die, right? This is in contrast to a passive euthanasia, aka letting someone die, and specifically withdrawing life support measures. So if you basically take away a ventilator or a nutrition tube, that person is going to pass away. Now, you aren't actively killing them, so they are you, right? Because you aren't pushing a medication, you aren't, killing them. You're just letting the natural process take hold. So some people make this distinction between active and passive euthanasia. The second distinction that we can kind of make here is between voluntary, involuntary, and non-voluntary. Voluntary euthanasia is basically where a patient requests or agrees to that particular thing. So many cases, right? Many cases that you can look up where patients request for their physicians or for someone to kill them because they don't want to go on living. That's a case of voluntary euthanasia. They're asking for that to happen. Involuntary euthanasia, obviously, is against the patient's wishes, and that's just taken as wrong, so not many cases really talk about this. Non-voluntary is a trickier one. What happens whenever the patient doesn't have competence or capacity to decide? Maybe they fell into a coma. And so after that, they just can't talk, right? That gets trickier. Typically in a hospital or typically in medical settings, next of kin will sort of decide what's going on. A life partner, for example, or children, if there are children. And if that doesn't happen, maybe a court appointed, maybe like a guardian ad litem or someone like that can make the decisions. But non-voluntary is an especially tricky aspect whenever it comes to, say, withdrawing life support. The person can't decide for themselves, so someone else has to decide for them, and it can be tricky to decide kind of what's going on. So these 5 distinctions, we've just talked about euthanasia, but they can be sort of mixed and matched according to these categories, right? And that can affect whether people will decide whether they are okay and whether they're not. Some philosophers are okay with voluntary euthanasia because it seems to go along with someone's autonomy. Some people aren't, right? Some people are okay with, most medical professionals who work in the area, they're okay with passive euthanasia, withdrawing life support that may lead to the death of that particular person, right? That is a standard practice. It is not a standard practice to actively do the killing to bring about the person's death, even when they're asking for it. In fact, it can be illegal in many states. This is what led to Dr. Kevorkian, Jack Kevorkian, being convicted for these types of things. All right? Things get complicated whenever we consider hospice care. Hospice is where you basically, you've been given a diagnosis. The medical team agrees that your condition isn't going to get better and that basically you're going to die. And so rather than die in a hospital, you get to go back home and you get to spend time with loved ones. You get to arrange your affairs, right? And nurses will still come by, they'll still check on you, and they'll give you usually palliative care or some side of like pain management to make you comfortable. Because basically you aren't going to get better if you go into hospice. That's the agreement. But they can nonetheless make you comfortable, right? But here's the thing. Sometimes hospice or medical professionals will basically say, look, if they're in pain, you can give them more of this. Let's say it's morphine, right? But I also want you to know that if you give them a certain amount of morphine, it's basically going to lead them to go to sleep forever. With the understanding that basically you could bring that person's life to end precisely whenever you want, right? And there are many cases of this. One of my favorite articles on this is Physician-Assisted Suicide or Physician-Assisted Death Ethical by Professor John Locke. He starts out with the case of Magda. Magda was a young woman, had been all over the world. She was incredibly independent, but as she got older and older, she started to outlive most of her friends. You know, she was in her 80s, but then by the time she was in her hundreds, she had outlived not only most of her friends, but also her doctors, right? But then increasingly she became more and more medically frail, and she, suffered lots of fractures. She couldn't even go to sleep laying down. She slept in a recliner. She basically had to wear diapers, and her adult children had to change her all of the time. She did not like the indignity of being alive. She, at one point, had saved up a lot of sleeping pills so that she could commit suicide, basically whenever she reached a point that she felt she had had enough, but she forgot where she put the pills. And so basically, whenever her case advanced, hospice told her family, here's the medications. You can give her as much as you need to keep her comfortable, etc. Right? And then John Locke reveals that that's the case of his mother. He's a renowned medical ethicist, okay? But I've always found that example incredibly jarring because it's him sharing how he and his family dealt with something that happened in their own life. Not an abstract issue. It was an issue that literally he and his family had to deal with. Okay? So these distinctions help us to differentiate between different types of euthanasia. Now, typically, this is talked about as aid in dying or physician-assisted death. All right? This was previously called physician-assisted suicide. They changed the name because suicide has negative cultural connotations. It's still heavily stigmatized, so they call it physician-assisted death, right? And aid in dying is the most neutral thing. Okay. This issue especially came to fore in the 90s because the state of Oregon passed the Death with Dignity Act that allowed patients who met certain criteria to seek a prescription from their physicians that they could take on their own time to bring about their own death. Now, there are similar laws in California, Colorado, Washington, D.C., Hawaii, Maine, New Jersey, New Mexico, Vermont, and Washington. So that's far from a majority of the states, but there are more and more states who are kind of signing on to this. How does this work? Well, typically, someone has to be a resident of that state, so they have to establish residency, and they have to have been diagnosed with some sort of terminal illness. So this illness is going to lead to their death, typically within a short time frame, probably a few months. We're talking like 6 months, maybe slightly more, slightly less. Terminal diagnosis, okay? They're not going to get better. Moreover, generally this is confirmed by multiple healthcare teams or multiple physicians. It's not just one thing. They want to be certain about this, right? Additionally, patients usually have to make multiple requests for physician-assisted death. So they say, doctor, I know that this isn't going to get better. I'm going to be in immense pain. I don't want to die in a certain way. I would like to request death with dignity. Meaning I want you to give me a prescription that can help me to bring my own life to an end with dignity. So the physician will take that into consideration. They might do a mental health assessment, treat depression or something like that if they see that that's a potential thing. And they will typically have some sort of waiting period. Okay? And then they'll come back, or the patient will initiate another request. Maybe it'll be multiple vocal or oral requests and then a written request. But they basically are checking to make sure that it is a stable wish. It's not something that immediately you can get, right? You have to make sure that the wish is stable. And then you get the prescription and you fill the prescription and you make final arrangements. But just because you give the patients the medication, it doesn't mean that they have to take it, right? It just means that they have the ability to end their life whenever they want, okay? Some patients take immense comfort in this. Rather than having to suffer an illness to the bitter end, and bitter meaning debilitating, excruciating pain that no medication can touch in some cases, right? They take comfort in knowing that they could end it at any particular time. Now, I had a student who looked into this once, and she said that the medications are an antiemetic, so basically something to prevent you from throwing up the medications, right? To help you to keep it down. And then it's a type of depressant, basically, and it's like 90 capsules, I think. So it's a lot of stuff to eat. You would dissolve it in a sweet drink, and you would drink it, and you basically just fall asleep and pass away fairly shortly. It's certain, right? And it works. And that's kind of what's going on. And there are documentaries out there on this that you can sort of look up. There are many, many news articles on this. And some people will basically plan their own funerals. And they will have their family there to reminisce with them for a little while. Maybe they'll listen, maybe they'll eat their favorite meal with their loved ones and play their favorite music and then lay down and take the medication to die, right? The ethical question is, should this be allowed, right? There's a legal question as far as legally, would we want to put this in place? What are the implications of doing this sort of thing? But ethically, we want to know on what grounds will we say that this is permissible or impermissible, okay? And there's a lot of issues to go through here. But I want in particular to focus on this article by John Hardwig because I think he does a really great job of summarizing a lot of what's going on in this debate in a sensible way. The first thing is, look, we agree that death generally can come too soon. A young person can die in a car accident, right? Something like that. But don't we also think that death can come too late? Aren't there certain ways of dying that are worse? That like there are things basically that are worse than death. enduring certain pains, seeing your family just like hurting while they can't do anything to help you, right? And so he says, look, I think death can't only come too soon, but it could also come late for lots of different reasons. Social reasons, emotional reasons, financial reasons. That's unfortunate, but that's a real thing, right? And so, whenever we look at these emotional burdens, it's really painful to watch someone die, and especially whenever you know that there's nothing you can do about it. Caregiving can become really intense. People can lose jobs because they basically switch full-time to becoming a caregiver of someone who needs intense caregiving, right? It can lead to an intense disruption of life. Not only loss of career, marriages can become strained, right? All sorts of stuff. And the financial things, as I mentioned as well. Because we live in a country that doesn't ensure medical care. Not the case in most countries that are as wealthy as us, but it is in our country. All right? So the tragic conclusion is that sometimes it's the best thing for us to die. It's the best thing not only for ourselves, but also for our families. They won't have to watch us suffer and suffer. They won't have to spend time caregiving. Their lives won't be disrupted. They won't have to spend money. Okay? Hardwig is kind of looking at these things holistically. And he says, let's just, say that there are cases where the best thing for a person to do is to die. All right? Well, given that, who should kill me? If I have a terminal illness, I'm in constant pain. I feel as though my family is in pain just watching my condition. There's rearranging their lives. They're spending a lot of money. I don't like this. I want to die. Okay? Who should kill me then? Right? Should it be myself? Because that's complicated. Physically, what happens if I'm unable? Like if I'm so weak from my illness that physically I literally can't kill myself. Psychologically, what happens if I just can't bring myself to do that? Even though I will affirm all of the time that I would like to die, I just can't do what needs to be done to kill myself. And in addition to this, the typical ways that people complete suicide are not very dignified. Okay? They're illegal. They don't leave the body in great condition. Whenever a family were to discover it, it would be kind of traumatizing with a lot of the conventional ways of completing suicide, right? And there's stigma attached to this. In addition to just insurance things, people who complete suicide, they might not even be eligible for certain insurance things. Okay? So there's a lot of considerations that basically point to, even if it's ethical in a certain way, there's a lot of other conditions to say that maybe I'm not the best person to complete my own suicide, right? So if not me, then should it be loved ones, right? So the benefit of this is that we would probably want loved ones, friends and family, to be with us whenever we're about to die, right? And, we can talk with them. This can be a social process. We can have lots of conversations. We can help them to understand what's going on, why I'm making the decisions. We can help them to prepare for my death, right? And doing this can sort of reaffirm, Hardwig argues, the connectedness that we have to one another, right? So maybe it should be the loved ones that help us to kill ourselves, right? But look, legally, it's a huge question. Would they be able to be convicted of murder? Right? And psychologically, what would be the psychological impact of someone actively killing a loved one, right? If my loved ones actually killed me, how would they be affected for the rest of their lives after having done that sort of thing, right? That puts up a lot of questions as well. So if I can't, bring about my own death, if my loved ones can't bring about my own death, who does that leave? Well, Hardwig says physicians, right? Physicians. And here's the thing. Physicians have lots of potentially good reasons for doing this. They understand the illness and the process of dying. They get it. They're trained to understand these things, okay? Not only that, but they have access to drugs that can basically help me to hasten my own death. Me drinking a solution that puts me to sleep and dies is way more humane than anything that my family or myself could do, right? Moreover, it's way more certain. Okay? And physicians are also trained to deal with this, and there's not stigma for being treated by a physician to do something in the way that there is stigma for completing suicide. Additionally, they already have professional obligations to help people. So what Hardwig basically argues is, look, it seems as though there are fates worse than death. And whenever we meet one of those, we can die too late. Sometimes it's best for us just to consider the facts and to bring about our own deaths, right? And you know, it's not in all cases, right? This can still be heavily regulated, like the Death with Dignity Act, terminal diagnosis, etc., right? So he's not saying in all cases necessarily. But if that's the case, if we really do sometimes have an ethical obligation to bring about our own death, literally just taking that prospect seriously and asking who will do that. And his answer is physicians are in the best, they're in the best position to do this. Okay, they're in the best position to do this. So physician-assisted death is really complicated, right? There's a lot of different issues. The first one is autonomy. Autonomy is self-rule, being able to make decisions for yourself. Some people argue about whether it's an affirmation or a negation of autonomy. So, for example, some people will say that you choosing to basically end your own life is you undermining your rational capacity to make decisions, because you're making a decision that's going to lead to your inability to ever make decisions again, right? That's a sort of Kantian argument against suicide. Some people, though, the Stoics, are going to say, no, it's actually an affirmation of your autonomy. What's more intimate and more important than you deciding how you die, right? So autonomy, I think, can go either way, and ethicists disagree as to whether physician-assisted death is respecting autonomy or undermining it, affirming it or negating it. Then there's beneficence and non-maleficence, doing good and avoiding doing harm. And the question here is, how do we assess the end of life, right? What do we make of those last few months where someone might be in a lot of pain, or they might have diminished capacities or whatever else? How do we assess that? Are we doing a good thing by helping someone to seek physician-assisted death, death with dignity? Are we helping them to avoid harms? Or are we depriving them of some sort of other good, right? Is just survival itself a good that should not be, taken away from anyone, even whenever they're requesting it, right? So beneficence and non-maleficence, this is kind of how we start to assess it. And then, of course, justice. Because here, one of the big questions is, if we make it legal for physicians to allow people to pursue physician-assisted death, will that pressure, for example, more poor people than rich people? Because financial stress, right? Social support. Rich people have jobs that give them time off. They already have money it's saved up for, tough occasions. The financial pressures aren't going to be felt. So is having a, legal out or a legal way to complete suicide, is that going to lead to, bad things that we don't want to encourage in society? Additionally, is that going to pressure people? Now here, this used not to be the case, but the Netherlands actually has physician-assisted death for pretty much any medical reason. And a lot of people were very worried that a lot of people were going to die. It ended up not being the case. Most people want to go on living, and they find comfort in the idea that they could end their lives if they ever needed to. But they've had very, very few instances of people, for example, requesting physician-assisted death because of depression, right? Most people, and in the Netherlands, they have public health care. Most people will just receive treatment for depression or whatever else it is. They will not want to kill themselves, okay? So justice, I don't think, is just an abstract thing that we, pontificate about. This is something where cross-cultural studies can actually help us to sort of understand what's going on. All right. Complicated thing. Obviously, we can't go into all the issues in one particular lecture, but these are the issues and these are the general reasons that people bring up. All right. So we've talked about the definition of death. We've talked about aid in dying. Now I want to talk about death culture. And the first thing that I want to do is just talk about how this is a really old problem. Okay, Epicurus, who died around 270 BC, he's really famous for his arguments against death. But basically, his philosophy is Epicureanism. It's a type of hedonism. And the best life, he says, is one where you avoid pains and you enjoy simple pleasures. Okay? So you avoid physical pains by taking care of your body. You avoid psychological pains by getting rid of anxieties. And you enjoy simple pleasures, right? Simple pleasures. You don't go after decadent pleasures. Those cost a lot of money. They're really complicated. They can make your life very strange. Enjoy like barley cakes and water, right? A basic diet. If you're hungry and thirsty, those things are going to taste incredible to you. Friendship, a basic good, but incredible. So if you want a full life, avoid pain and enjoy simple pleasures, okay? But what was one of the things that he spent a lot of time talking about to help people dispel anxieties? Death. A lot of people are afraid of death. So the Epicureans spend a lot of time talking about death and why it's not actually something to fear. And so here's a quote. A correct knowledge of the fact that death is nothing to us makes the mortality of life a matter for contentment, not by adding a limitless time to life, but by removing the longing for immortality. For there is nothing fearful in life for one who has grasped that there is nothing fearful in the absence of life. Thus, he is a fool who says that he fears death not because it will be painful when present, but because it is painful when it is still to come. For that which while present causes no distress, causes unnecessary pain when merely anticipated. So, death, the most frightening of bad things, is nothing to us, since when we exist, death is not yet present, and when death is present, then we do not exist. So this is a sort of famous argument from the letter to Menoetius, and he's basically saying that whenever you die, you aren't around. You can't feel, right? And there's no need for you to fear death, right? Because you anticipating death and feeling anxiety about it is adding harm to your life, and you aren't dying, right? Why are you adding the harm of anxiety to your life? Why don't you just realize that death is a natural part of life, and once it happens, you don't suffer anymore, right? It's okay. And he has this refrain, death is nothing to us. Death is nothing to us. And so he spends a lot of his philosophy trying to explain why that's the case. 270 BC, right? That's a long time ago. Seneca the Younger, a Stoic philosopher, says similar things. Look, he says, we do not receive a life that is short, but rather we make it so. We are not beggars in it, but spendthrifts. Just as great and princely wealth, when it falls into the hands of a bad owner, is squandered in a moment, while wealth that is by no means great, if it becomes the property of a good guardian, grows by use, so our span of time has ample measure for one who manages it properly. So he spends a lot of time talking about life and death, and he says, look, a lot of people are going to say that life is really short, man, but it's not. We have enough time. We can do lots of stuff with it. And if anything, what separates short from long lives is that people who complain that life is short squander their time. And no matter what our fortunes are, we can sort of make the best of what we have. So Seneca, again, Stoic philosopher, different from Epicurus, the Epicurean, talking about death and why people fear it. And he says, look, if you just pay attention to life, Pay attention to what you do. And he spends a lot of time in this particular essay just kind of talking about how you should not have such ambitions that take you away from living your life and doing meaningful things, right? Don't go chasing reputation. Don't go working too hard. Focus on the things that matter most. This is one of the things that he emphasizes. Epictetus, so slightly later, he argues a couple of different things in his handbook, and in particular he says this: let death and exile and everything that is terrible appear before your eyes every day, especially death, and you will never have anything contemptible in your thoughts or crave anything excessively. Epictetus is another Stoic, and he just says, look, if you keep death in mind, that's going to keep you from taking things for granted. It helps you to prioritize your life. What are the things that you're going to consider on your deathbed? You're not going to consider that you should have worked that extra shift. You're not going to consider that like you really would have liked your neighbor to like you more, right? Or invited you to like more Christmas parties. What you are going to care about is, the things that you spent your time on, spending time with loved ones, right? And whenever you focus on death, Epictetus says, or at least keep it in mind every now and again, what you do is you get rid of a lot of the false things that a lot of us focus on. It's really easy. It's really, really easy to get caught up in reputation or in work or whatever else. But if you actually realize that you're going to die someday, it helps you to prioritize your life on the things that matter, right? And then the last thing, and he's quoting Socrates here, he says, Anytus and Meletus can kill me, but they can't harm me. They can kill me, but they can't harm me. And this is a sort of Stoic idea that like death isn't a harm, or it's not the harm. It's not the bad, right? There are things worse than death, namely losing control over my life. So I should be able to end my life whenever I want. And basically living my life in such a way that I've lost focus on what actually should be prioritized and how I should be living, right? That's way worse than death. Way worse than death. But these are ancient, right? And a lot of people don't really think too much about death, especially in America where we have, clinical medicine in a sterile environment where we don't even kill animals whenever we eat. I mean, some people who live in the country still do, hunters still do, but not a lot of Americans. Even whenever a loved one dies, the funeral home takes away the body almost immediately and embalms it so that it doesn't decay over the course of, the funeral rituals, right? Americans don't have a culture where we talk about death very often. And this has led to a lot of people trying to create a death positivity movement. And one of the big players here is Caitlin Doughty. And that's why we read her book From Here to Eternity, right, for this particular class. And I like it because, well, first of all, I think she has like a really funny literary voice. She's kind of a funny woman. She has a podcast. She has YouTube videos. You can totally check her out if you like the stuff that she was talking about. But she writes this book, and in particular, she has criticisms, especially of American culture, because she lives in LA, right? And one thing that she laments is the commercialization of death. Okay, there are a lot of funeral companies that make a lot of money on death care. And they do things that are ethically questionable. I mean, like the first thing that's really intense is that the average funeral in America costs $8,000 to $10,000. That's a lot of money. And there are a lot of families that can't pay that, especially if the person doesn't have life insurance through an employer or whatever else, right? That's a lot of money. By contrast, the funeral pyre that she talks about in Colorado costs $500. Okay? And the funeral companies that are doing this sort of stuff, they often use pressure sales tactics and upselling tactics to try and get people to buy extra fancy coffins or extra rituals or whatever else it is. They upsell them to have a particular experience of a funeral. And she says, that seems really messed up. You're taking advantage of grieving families and you're making them spend a lot of money, and it doesn't really help them with closure either, right? So she looks at the funeral industry and she just sees that there are a ton of ethical problems. And I agree with her 100%. And so she says, look, part of the solution here is just death education. We have to educate people about what you can do with the corpse. So, for example, the family can keep it, right, after the coroner has pronounced them dead. You can do certain things to help preserve this. You can hold a wake at home. This is the way it used to be, even though it's not often the case with how it is now, right? And you can also inform people on what the various options are. Cremation versus burial, different types of burial, what all the options are, right? And that's something that can really happen through death education, but you can't do that if you aren't facing it, right? And so this gives rise to the second problem, which is death avoidance or a lack of ritual. And so especially for Americans, she says, we as a culture just don't deal with death. We don't think of it. We don't deal with the ritual. And so she wrote this book. And so here's where I'm going to show some pictures of potentially disturbing things, but they're things that she talks about in her book, and she has illustrations, but I found some photos from the internet, okay? I forgot that I gave her a quote. Okay, so here she explains. Death avoidance is not an individual failing. It's a cultural one. Facing death is not for the faint-hearted. It's far too challenging to expect that each citizen will do so on his or her own. Death acceptance is the responsibility of all death professionals, funeral directors, cemetery managers, hospital workers. Holding the space is crucial and exactly what we are missing. To hold the space is to create a ring of safety around the family and friends of the dead, providing a place where they can grieve openly and honestly without fear of being judged. In our Western culture, where are we held in our grief? So she doesn't think that it's any individual's fault. She thinks that there's something wrong with our culture that's leading us not to consider things about death, and this is leading to bad stuff, right? We need to consider death. So she wrote this book. Here are some examples, okay? So this is the Crestone, Colorado community funeral pyre. Costs around $500 to get the funeral here. You can arrange casual to like really formal things here. But basically the body is directly cremated in front of the friends and family, and they can take the ashes away from that, right? Costs $500 as opposed to $8,000. It's not all that terrible for the environment. They've done studies on this. It's better than other pyre sort of methods. Now, you can't do this unless you're a member of this particular community at this place, and people fight it. And there's a lot of economic interest, right? If you're a funeral company that's making millions of dollars on selling people very expensive funerals, you're going to do everything you can to undermine something like this. And they face lots of legal challenges. They also face social challenges, right? About where the smoke would be, whether it was too morbid, etc. But after more talk with the community, eventually this community found, they agreed to do this, and the community came to kind of love it. And they have more and more people choosing this particular method of funerary rite. Okay. This is from Indonesia, Toraja, and this is the Ma Nene. And this particular ritual is basically, in these cultures, they keep the bodies of the deceased with them. They could be in a crypt, they could be even, at the house. And every year there's a ritual where they take care of the corpse. They redress it, maybe they give it things, they parade it around, and it's a way for them to remember the dead. And there's even like a point in the book where one of the people from Indonesia is like, hey, that's going to be me someday. Man, that's going to be me, right? So it's a way of keeping the dead alive through memory, but also contemplating death because you see yourself in the corpses, right? And this is a way that this particular society has thought about this. Now, it's kind of morbid and it's kind of grisly, right? So maybe it's not something that America could do, but it shows how there's a different way of dealing with death than we deal with it, right? Mexico obviously has the Dia de los Muertos, the Day of the Dead. And this lasts for about a day, 2 days. And basically, you build altars and you put pictures of the deceased, you put their favorite food and drink, you put prayers, light candles, you spend time with your family and friends, and you invite the dead to live with you, right? There's a way of keeping the dead alive every single year because you think about all of the people who you've loved, friends and family, who you're inviting to come spend some time with you, right? And you give them their favorite things. You contemplate this. It's a space for families to grieve and celebrate, both at the same time. Tokyo, Japan, it has a Buddhist temple, and this is the Ruriden Columbarium. And each of those Buddhas, each of the squares in the wall is a Buddha that has a drawer that has the cremated remains, which is the popular way of dealing with death in Japan. And basically you can go in and there's multiple ways. You can enter in a number, you can swipe a card or whatever, and it will light up the drawer that is your particular family member. But there are, monks who will pray for the dead, right? And so again, this is a case where they've made a sacred space. It's a really stunning space, right? For family members to go in, to leave flowers or whatever memorials, to pray, light incense, all those types of things. But it's also really highly technological. Look at how gorgeous that is. You swipe a card so that it shows you where the remains of your family or your loved ones are, right? And so all of these cultures have found different ways, more technological, less technological, more literal in the case of the Manene, less literal, spiritual in the case of Day of the Dead, right? Ways of dealing with things. So what's Doughty's conclusion? Holding the space doesn't mean swaddling the family, immobile in their grief. It also means giving them meaningful tasks, using chopsticks to methodically clutch bone after bone and place them in an urn, building an altar to invite the spirit visit once a year, even taking a body from the grave to clean and redress it. These activities give the mourner a sense of purpose. A sense of purpose helps the mourner grieve. Grieving helps the mourner begin to heal. So whenever she looks at these rituals, she's not necessarily prescribing that America should do exactly these things. America still needs to be America. But we do need ritual with meaningful activities that can help people to grieve, that can help people to understand death, that can help people to remember and feel what they need to feel, right? And it's only through doing those types of things and being meaningful and confronting those things and considering how we as a society want to handle something like death that we can allow people to grieve, right? So her recommendation is to use spaces, to make spaces, and to get active. Look, attend the wakes, attend the funerals, right? Dress the body if you want to do that. If they get cremated, keep it at home. Whatever it is, get active in the death care. Don't just, put it off. Don't just keep it out of mind. The idea here is to comfort it and to find a good way of dealing with these particular things. All right. So in this lecture, I've talked about 3 different issues, right? I talked about the definition of death. I talked about physician-assisted death, and I talked about death rituals. And all of this is just to kind of give you some different ways of dealing with things. Consequentialists are going to assess things as to whether it leads to more good than bad. Kantians are going to assess things as to whether it respects the dignity of people or whether all rational people could do it. Virtue ethicists and care ethicists are concerned about what is the person like who does these things? What kind of person would do these things? What kind of life can we lead? Hopefully a good, flourishing, meaningful life whenever we do these things, right? And then we have the four principles: beneficence, actively doing good; non-maleficence, avoiding doing bad; autonomy, which is us being able to decide what to do for ourselves; and justice, making sure that the benefits and the burdens of society are distributed correctly. So thank you so much for paying attention, and thank you for considering some of these thoughts with me.